This is Red Essay Season 2. This season, we're taking a moment to highlight the leaders in our Native communities. Leaders in academia, entertainment, tribal politics, satellite communities, authors, speakers. These are the people that continue to transcend their blue card to make a positive difference in the Indigenous world today and for the future of our people. So without hearing much more from me, enjoy Red Essay. Hey everybody, welcome to another episode of Red Essay. My name is Brandon Caruso, and today I'm going to have Melissa Lewis joining the show as my guest. And Melissa is an assistant professor at Duluth in the Biobehavior Health and Population Sciences Department. I'll admit I had to write that one down. Basically, she studies behavior and mental health, and more specifically, how it relates to American Indian health. Now, Melissa's somebody I met more recently, actually. It was at a dinner party where we had a conversation on the behavior and mental health for Natives, and I was completely fascinated by her knowledge and her work that she's doing, not only in Duluth with her colleague Laurel Myra on integrated care research with Indigenous patients, but also what's going on a nationwide level. And she's going to be speaking about that and what clinics are now available, as well as what's happening at the University of Washington. Now, I got to admit, this isn't really my field, so some of these questions might seem a little bit ignorant, so bear with me. But I think anybody's going to find it very fascinating, as these Native health problems really affect everybody in the community. And Melissa's also going to be talking about scientific racism. Now, this is a new term for me, but it's referring to the lack of evidence that there is right now for these beliefs of being predisposed for alcoholism or diabetes. So without further ado, here's Melissa Lewis. Enjoy the show.
I'm at the medical school at University of Minnesota, Duluth, and I'm an assistant professor in the Biobehavioral Health and Population Sciences Department. And so it's a department that specifically combines, behavioral health and medical health, because we know that behavioral health is such a critical part of our total health. And it's also the only medical school in the country that I know of, and I'm doing research on this, so I believe this is accurate. It's the only medical school in the country that its mission is both rural health and American Indian health. So it has a pipeline program to train Native American students starting in 7th grade, although they have a coloring book starting in kindergarten. We have 6 Native American faculty at the medical school. And I'm a licensed marriage and family therapist, but my degree is in medical family therapy, so that's specifically studying and doing the clinical work of that integration. What does a behavioral health specialist look like in a health clinic setting? And then also the research on that, which is how effective is this kind of care, which they call biopsychosocial spiritual care. So it's a whole body care. And, right now the evidence is looking pretty good, especially with vulnerable and hard to reach populations and comorbid populations, which, makes me think about Native communities. And so that's one of the pieces of research I'm doing right now to see how effective this integrated care is with Native communities. I'm working with a Native woman from Red Lake, who is the clinical director of the Native American Community Clinic in Minneapolis. So she's kind of on the ground doing it right now.
So what is the difference between a Native American clinic and the normal everyday clinic?
Well, most clinics, a couple of things happening. One, in any clinic anywhere, a large majority of the population does suffer from mental health symptoms or disorders, yet they have very few behavioral health people on staff, and the physicians aren't trained to diagnose or treat mental health problems. So, for instance, at one study said at Indian Health Service at IHS sites, about 60% of the presenting problem was a mental health problem and not a physical problem. So what we also know is that the majority of people who commit suicide have seen a physician within the last month, yet the physician never screened them for depression or substance abuse. So, at these integrated care clinics, like what NAC in Minneapolis is trying to do, is to combine these services. And they actually have, they're moving towards a waiting room that has dental patients, medical patients, and mental health patients. But not only are they combining services in that way, they're doing things like adding depression screens and substance abuse screens, very brief ones, PHQ-9, 9-item scale. It takes patients, less than a few minutes to do to every one of their visits, so then a physician can see very quickly, is my patient having depressive symptoms? And if so, how can I coordinate with my behavioral health care specialist to address this? And they are doing a thing called the diabetes clinic because, again, we know that people who have depression are more likely to have diabetes, and people who have diabetes are more likely to have depression. It's just this bidirectional relationship, yet in most clinics and most healthcare visits, the only one kind of health is assessed, which is that physical health. So this is, integrated care or collaborative care is one of those ways to try to bridge those gaps.
That's great. So for someone that is a young aspiring RN, per se, or wanting to pursue healthcare, what would they expect to be any different from a state institution than going to a university that tailors towards Native American health?
Well, I think it's changed a lot over the years, where one of the first problems was just getting Native students to medical schools. And so there's been a push for recruitment and retention, just having Native students. Native students are more likely than non-Native students to have lower quality education, and therefore there's a lot of barriers to get to medical school. So that was kind of step one. And I think we're now in a new era where we don't just want Native students to come to a medical school and learn how to become a doctor in Western terms. Now it's time to kind of, for lack of better words, to indigenize the institution, indigenize medical education. So what we're doing here in Duluth is I, with some colleagues, put together a retreat of community members, of medical students, and of Native and non-Native faculty. And we said, what have been your barriers to getting good quality care? And what are the things that medical students, and we just have them for the first 2 years, what do they need to know to be on this path to be able to serve Native patients in an effective way? And this is for Native and non-Native medical students. And so this semester, it's going to be the first semester where we add to a foundation course. It's a rural medicine course. It's foundation, meaning that all medical students have to take these courses. We added about 6 to 8 hours of education, and just around Indigenous health. And some of the classes include, resiliency, culture, and spirituality. Some of them are basic history courses that many students never get taught. We go a little bit deeper into the origins of medicine and the origins of scientific racism and ethics of medicine, and how there's been a really, in a lot of ways, negative relationships between academia, research, the medical world, and minority populations, and specifically Native populations. So we go through that information, then we're going to go to, so what can you do? And so we're going to have some people that come in are going to talk about language revitalization and cultural revitalization happening here in Ojibwe communities. We're going to talk about community-based projects and how to let community lead in these healthcare interventions. And we'll see. I'm hoping to do a pre- and post-test this semester to see if students our learning, and we'll see if we can track these students over time. My wish is that we could, see if more students are more likely to go to Native serving sites after this training, and if they feel like they're more culturally competent after this kind of training. We'll see.
That's really interesting. Yeah, I look forward to hearing more about the follow-up, because you mentioned that Duluth was, as far as you know, the only place in the country doing anything like that.
Well, there are some places doing really, really cool things. Duluth happens to be the only one where it's actually in their medical school mission. That American Indian Health is in its mission. There's places like, University of Washington. I'm actually at a conference right now with one of the physicians who, she is also a practitioner of plant medicine, but she's also an MD. And, hopefully, University of Washington has a really, really neat model where they have almost like a minor. They have a pathway in Indigenous health, and that's one class and an internship. And they added this year, and I think they're the first ones to ever do this, a traditional Indian medicine preceptorship, where physicians, instead of going on their kind of usual rotations to internal medicine or a rural location, students in this pathway can choose to go with her. And I was actually able to go to one of the classes where we did some plant foraging and plant identification and, really kind of just learning about plant medicine. And, there's also readings and things, but it's really experiential more than anything else. And the purpose is not to train people to be healers, but to be able to really collaborate with them and to be able to know when you go to a Native community what questions to ask, like, who are your traditional healers? Where are they? What kind of relationships do you have with them? What things happen during each season, and what happens in the landscape, and how does the community change based on that landscape? What kind of food do you use? What kind of medicine do you use? So that's Terry Maresca, and she's actually here in Duluth presenting. We kind of have a close and tight-knit circle between the medical schools who have this as a focus.
Wow.
And they're really leading in a lot of ways, too.
That's awesome. And I know, so you're talking a lot about what's going on in the community and being, sensitive to that. And excuse me if this is an ignorant question, but is there anything different with the physiology of someone that has Native descent? I mean, I've heard things that you're more prone to, say, diabetes is the big one, but are you finding any truth behind that?
Well, I, again, am just a licensed marriage and family therapist, and I do research and literature reviews on these kinds of topics, but I am in no way an expert. What I have understood is that might be a product of what we kind of call scientific racism, and it was a popular theory a few decades ago, and at this point, there's things like the thrifty gene. That was one of those, I think, that you're referring to. There was these theories that Native people they were more genetically prone to diabetes, more genetically prone to alcoholism. And from what I understand, there isn't any evidence to support that at this time. And the evidence that is really mounting is colonialism, historical trauma are really more at the root of some of these health disparities that we see for Native people now than any other reason.
Wow. What do you see for the future of Native health?
Well, I think it's a really exciting time because we have a lot more Native physicians. We have 6 out of 60 in our class every year. Just here, for example, we have a lot more Native behavioral health care professionals, a lot of Native administrators. So I think we're really kind of decolonizing all of these areas. I know some interventions in different communities are really partnering with the community for the first time ever. There's kind of a movement called culture as treatment. So, for example, specific communities, folks can, instead of doing an inpatient alcohol abuse, they can choose to learn more about their culture. It's kind of partnered with the language revitalization, the cultural revitalization, and, kind of reclaiming our foods, reclaiming our medicines, and reclaiming our own health and our own health care. I think for the first time, it's not really going to look like that Western medicine is going to just be the dominant source that we're going to use. I think we're going to get to a place where people can have a choice, and maybe can even combine Western medicine and traditional medicine in their own cultural and tribal way, which I think is pretty exciting.
Wow. Yeah, absolutely. That's great. Okay, well, thank you again so much for spending your time with me and helping to understand a little bit more about the work that you're doing, and I definitely find it really exciting. I don't know much about that field, but I think it's incredibly important, and it's great to know that we have some Cherokees out there doing some good work.
Hey, have you checked out the Cherokee Scholars website before? It's a list of Cherokees with PhDs, really, in lots of different areas. That might be another source of folks you would want to interview.
Oh yeah, okay. Thank you. I appreciate it. I'll definitely check that out. Absolutely.
Okay. I hope you have a great weekend.
Okay, you too, Melissa.
Okay.
Take care.
Bye-bye.
Bye. Big wado to Melissa for coming out and sharing her knowledge on the show. It's really exciting to see somebody both involved in the Native community plus the academia and medical communities all at the same time. I think she's going to make some huge influences in a big positive way, so I look forward to hearing more about the future of Native health and these Native American students coming back to their communities and helping out in their own way too. So I hope you enjoy the show, and we'll see you next time on Red Essay.